Swallow once, just once, and notice what you feel at the back of your throat. Is there something sitting there? A thickness? A coating that just will not go away no matter how many times you clear your throat? You have probably been clearing your throat dozens of times every single day. And if asked when it started, you might not even be able to give a clear answer. It crept up on you slowly. First it was just mornings, then it was all day, and now it is just part of your life. You carry water everywhere. You avoid certain foods. You have probably tried every home remedy your neighbors and relatives could suggest, and yet here you are. That mucus is not random. It is not simply your age catching up with you. Your body does not do things randomly. Every persistent symptom is your body's way of communicating something specific. The question is whether you know how to listen. The scope of the problem. Chronic throat mucus is one of the most commonly dismissed symptoms in all of medicine, and that dismissal comes at a real cost to quality of life. It affects sleep, interrupts conversations, creates social awkwardness, and feeds a persistent low-grade anxiety that something more serious might be wrong. For most people, the first explanation offered is allergies. The second is post-nasal drip from sinus issues. Both of these are real conditions, and they do cause throat mucus in many people. But here is what most people are never told. When throat clearing, persistent mucus, and that lump in the throat sensation continue for months or years, fail to respond to allergy medication or nasal sprays, and are not accompanied by classic heartburn, there is a different and far more commonly overlooked cause that deserves serious consideration. It is called laryngopharyngeal reflux, often shortened to LPR, and it is frequently called silent reflux because the majority of people who have it never experience the burning chest sensation most of us associate with acid reflux at all. Understanding the anatomy, why the throat is different. To understand why LPR causes mucus, while traditional reflux causes heartburn, it helps to understand the anatomy involved. The esophagus, the tube that carries food from your mouth to your stomach, is built to withstand occasional exposure to stomach acid. Its lining is stratified squamous epithelium, a type of tissue that is relatively tough and resistant to chemical damage. This is why people with GERD can experience heartburn for years without permanent damage to the esophagus itself. The throat, voice box, and upper airway are different. They are lined with a much more delicate tissue called respiratory epithelium. This tissue is highly vascular and richly innervated, meaning it has many blood vessels and nerve endings. It is designed for air exchange and vocalization, not for exposure to digestive juices. When acid and pepsin reach this tissue, the response is immediate and intense. Inflammation, swelling, and a cascade of protective mechanisms, including the production of excess mucus. This is why a small amount of reflux that would cause no symptoms in the esophagus can cause significant throat symptoms. The tissue simply is not built for it. The science, pepsin and tissue damage. Here is what most people do not realize. Pepsin, the digestive enzyme involved, has been detected directly in the nasal and throat tissue of people with LPR. This means the irritation is not simply caused by acid alone. It is active enzymatic damage to delicate tissue that was never designed to come into contact with digestive enzymes at all. Pepsin works by breaking down proteins. When it lands on the protein-rich surface of your throat tissue, it begins digesting it, literally breaking down the structural proteins that keep the tissue intact. This triggers an inflammatory response. The tissue swells, the nerve endings become hypersensitive, and the tissue responds to this damage the only way it knows how, by producing more mucus to try to protect and coat itself. Research has demonstrated that pepsin can remain attached to throat tissue for hours after a reflux event, continuing to cause damage long after the acid has been neutralized. This is why simply taking an acid-reducing medication may not fully resolve LPR symptoms. The pepsin is already there, already bound to the tissue, and continues to cause irritation until it is cleared away by the body's natural repair processes. One study published in the journal Laryngoscope found that pepsin was present in the throat tissue of over 90% of patients with LPR symptoms, compared to less than 10% of healthy controls. This is not a subtle difference. It is a clear biological signal pointing directly at the mechanism driving the symptoms. The pepsin trigger model. Why LPR is different from GERD. Here is another critical distinction. In GERD, the primary driver of symptoms is acid itself. The lower esophagus is sensitive to acid, and when acid refluxes upward, it causes the burning sensation we call heartburn. In LPR, acid is still involved, but it is not the whole story. Acid acts as a delivery mechanism. It carries pepsin upward and activates it. Pepsin is most active in an acidic environment. Once it reaches the throat and the pH rises, becomes less acidic, pepsin remains attached to the tissue and can be reactivated by future acid exposure, even from acidic foods and beverages like coffee, citrus, or tomato products. This is called the pepsin trigger model. It explains why people with LPR often experience symptoms after eating acidic foods, even if they are not having a traditional reflux episode. The pepsin is already there, sitting in the tissue. An acidic meal or drink reactivates it, and the tissue damage begins again, without any new reflux event occurring. This model also explains why some people with LPR experience symptoms in response to non-acidic triggers, like stress, certain medications, or even changes in posture. The pepsin is already present. The trigger is whatever reactivates it. Why classic heartburn is often absent. This explains why classic heartburn is present in only a small fraction of people with LPR. Research indicates that GERD symptoms are clinically silent in a large majority of patients whose chronic throat symptoms are ultimately traced back to reflux. Here's why. The esophagus has pain receptors that respond to acid exposure. That is what produces the burning sensation. The throat and voice box have fewer of these specific pain receptors, but they are highly sensitive to irritation and inflammation in other ways. So someone can have significant pepsin-related tissue damage in their throat without ever feeling the classic burning sensation. Their symptoms manifest as mucus, throat clearing, hoarseness, and cough instead. This means the absence of heartburn does not rule out reflux as the cause of your mucus. In fact, for most people with this specific pattern, the absence of heartburn is actually typical, not unusual. This is the single most important concept to understand if you have been chasing allergies or sinus issues for years without relief. What LPR actually feels like, the complete symptom list. If not heartburn, what does LPR actually feel like? Here are the early warning signs and hidden risk patterns that most people have experienced for years without ever connecting the dots. 1. Globus sensation. A persistent feeling of a lump or thickness in the throat that is present regardless of whether you have eaten recently. It may feel like something is stuck in your throat. Swallowing does not make it go away. Some people describe it as a tightness or a pressure sensation. 2. Frequent throat clearing. This has become such a habit that you barely notice yourself doing it anymore. It often happens multiple times per hour, especially after meals or when lying down. The urge to clear your throat is driven by the sensation of mucus or irritation. 3. Hoarseness or voice changes. A mild ongoing hoarseness or change in voice quality, particularly noticeable in the morning. The voice may sound raspy, weak, or lower in pitch than usual. Professional voice users, such as teachers, singers, or public speakers, often notice this change more acutely. 4. Post-nasal drip sensation. A sensation of mucus dripping down the back of the throat that never seems to fully clear, no matter how many times you swallow or clear your throat. This is often misattributed to allergies or sinus issues. 5. Chronic dry cough. Especially one that worsens at night or shortly after lying down. The cough is typically dry and non-productive. It may be triggered by the irritation of pepsin on the vocal cords and upper airway. 6. Mild sore throat. A sore throat that comes and goes without any clear cause, like a cold or infection. It may be worse in the morning or after meals. It is not severe enough to seek medical attention on its own, which is why it is often dismissed. 7. Difficulty swallowing. Some people experience a sensation that food or liquid is sticking in the throat. This is usually mild and intermittent. 8. Excess saliva or water brash. Some people produce excess saliva or experience a sudden sour taste in the mouth, often in response to reflux events. 9. Bad breath. Chronic irritation and pepsin exposure can contribute to halitosis, bad breath, that does not respond to typical oral hygiene measures. 10. Voice fatigue. The voice tires more easily than it used to. Speaking for extended periods becomes effortful, and the voice may crack or fade, the pattern that almost nobody connects on their own. Symptoms are frequently worse in the morning because the time spent lying flat overnight allows stomach contents to travel upward more easily than they do while you are upright and gravity is working in your favor during the day. They also tend to worsen after meals, particularly large or fatty meals, and after consuming certain trigger foods or beverages. Risk factors for LPR. Several factors increase the likelihood of developing LPR, particularly in older adults. 1. Age-related changes. As we age, the lower esophageal sphincter, the muscle that normally prevents stomach contents from traveling upward, naturally weakens. This is a normal part of aging, but it means that older adults are more susceptible to reflux of all kinds, including LPR. 2. Hiatal hernia. A hiatal hernia occurs when part of the stomach pushes upward through the diaphragm into the chest cavity. This mechanically disrupts the normal barrier between the stomach and the esophagus, making reflux more likely. 3. Obesity and abdominal weight. Excess weight, particularly around the abdomen, increases intra-abdominal pressure. This pushes stomach contents upward more readily, increasing the risk of both GERD and LPR. 4. Dietary factors. High-fat meals, large portion sizes, caffeine, alcohol, chocolate, and acidic foods all relax the lower esophageal sphincter or increase stomach acidity, making reflux more likely. 5. Medications. Certain medications can relax the lower esophageal sphincter or slow gastric emptying, increasing the risk of reflux. These include some blood pressure medications, benzodiazepines, and NSAIDs. 6. Smoking. Tobacco smoke irritates the throat tissue and relaxes the lower esophageal sphincter, increasing reflux risk. 7. Stress. Stress increases stomach acid production and can alter the normal motility of the digestive tract, making reflux more likely. Common mistakes people make. Mistake number 1. Treating allergy medication as the long-term answer simply because it provides partial relief. Antihistamines and nasal sprays can reduce some mucus production through entirely different mechanisms. This means someone can experience mild improvement and conclude allergies were the cause, when in fact an underlying reflux pattern continues unaddressed in the background. If you have been using allergy medication consistently for months without ever achieving real, lasting relief, this is worth reconsidering with your doctor. Mistake number 2. Waiting for heartburn before considering reflux as a possible cause. As covered, the clear majority of people with throat-focused reflux never experience classic heartburn at all. Waiting for that symptom to appear before investigating reflux means many people go undiagnosed for years, sometimes decades. Mistake number 3. Self-diagnosing and beginning acid-reducing medications without proper evaluation. While certain acid-reducing medications can help in confirmed cases, current clinical guidance specifically states that medications should be used only after objective testing, such as pH monitoring or a laryngoscopy examination, rather than started blindly. Self-treating without diagnosis can mask symptoms, delay proper evaluation, and in some cases is simply the wrong approach if a different condition is actually the true underlying cause. Mistake number 4. Stopping treatment too soon. LPR is a chronic condition that requires consistent management over months, not days. Many people try a lifestyle change for a week or two, see only modest improvement, and assume it is not working. In reality, the tissue in the throat takes time to heal, typically 3 to 6 months of consistent management before full resolution is achieved. Mistake number 5. Focusing only on acid and ignoring pepsin. Because pepsin can remain attached to throat tissue and be reactivated by acidic foods and beverages, managing LPR requires paying attention to acidic triggers, not just reflux events themselves. This means avoiding or reducing acidic foods and beverages, not just taking acid-reducing medication. What to do? Comprehensive practical solutions. Step 1. See your doctor and specifically mention the possibility of laryngopharyngeal reflux by name, particularly if you have had persistent throat mucus, throat clearing, or hoarseness for more than a few months without a clear allergy or infection explanation. Asking about LPR specifically often prompts a more targeted evaluation than describing only the mucus symptom alone. A proper evaluation for LPR typically includes a detailed history of your symptoms and their timing, a laryngoscopy examination where a small camera is passed through the nose to visualize the throat and voice box. This can reveal characteristic findings of LPR, such as redness, swelling, or thickening of the tissue. In some cases, pH monitoring to measure acid exposure in the throat over 24 hours. In some cases, a trial of lifestyle modifications and medication to assess response. Step 2. Implement evidence-supported lifestyle changes. These are the foundation of LPR management and are effective regardless of whether medication is ultimately prescribed. A. Elevate the head of your bed. Not just using extra pillows, which can actually increase abdominal pressure and worsen reflux, but actually raising the entire head of the bed frame by 6 to 8 inches. Blocks or risers placed under the legs of the headboard are inexpensive and effective. This uses gravity to help keep stomach contents where they belong during the night, when symptoms are typically at their worst. B. Avoid eating within 3 hours of lying down or going to sleep. A full stomach combined with a flat or reclined position is one of the most reliable triggers for reflux to travel upward. Give your stomach time to empty before you lie down. C. Be mindful of common trigger foods and beverages. These include caffeine and caffeinated beverages, coffee, tea, soda, alcohol, acidic foods, citrus fruits and juices, tomatoes and tomato products, vinegar, very fatty or fried meals, chocolate, mint, carbonated beverages, spicy foods. All of these are recognized risk factors that can relax the lower esophageal sphincter or increase the acidity of what refluxes upward. D. If you are carrying excess weight, particularly around the abdomen, even modest weight reduction, as little as 5 to 10% of your body weight, has been shown to meaningfully reduce reflux symptoms. Increased abdominal pressure is a well-documented contributor to reflux of all kinds. E. Pay attention to portion sizes. A very large meal at any point in the day increases stomach pressure and the likelihood of reflux occurring afterward, regardless of what specific foods were eaten. Several smaller meals throughout the day, rather than 2 or 3 very large ones, is a pattern that clinical guidance on reflux management consistently supports. F. Avoid tight clothing around the abdomen. Tight belts, waistbands, or shapewear can increase intra-abdominal pressure and promote reflux. G. Stay upright after meals. Avoid lying down or reclining for at least 2 to 3 hours after eating. If you need to rest, sit upright in a chair rather than lying on a couch or bed. H. Chew sugar-free gum after meals. This stimulates saliva production, and saliva is naturally alkaline and contains bicarbonate, which helps neutralize acid in the throat. I. Drink water throughout the day, but avoid large amounts with meals. Small sips during meals are fine, but large volumes of liquid can distend the stomach and increase the risk of reflux. Focus on drinking water between meals instead. J. Identify and reduce personal triggers. Keep a symptom diary for a few weeks. Note what you eat and drink, when you eat, and when your symptoms occur. This can help identify specific triggers unique to you. Addressing dietary acids and pepsin reactivation. Because pepsin can be reactivated by acidic foods and beverages, managing LPR also involves managing dietary acidity. This is separate from managing reflux events themselves. Foods and beverages with a pH below 4.0 are considered acidic enough to activate pepsin. Common culprits include citrus fruits and juices, orange, grapefruit, lemon, lime, tomatoes and tomato products, ketchup, pasta sauce, salsa, vinegar and pickled foods, carbonated beverages, cola, sparkling water, coffee and black tea, both acidic, alcohol, particularly wine and beer. It is not necessary to eliminate all of these foods entirely. However, reducing their frequency and amount, particularly in the hours before lying down, can significantly reduce pepsin reactivation and symptom severity. Other conditions that can mimic LPR. Salivary gland dysfunction. Reduced saliva production can produce a strikingly similar sensation of thickness and dryness at the back of the throat, sometimes alongside an increased perception of mucus, even when actual mucus production is not elevated. Research investigating globus sensation has specifically explored salivary hypofunction as a potential contributing cause in patients who do not respond to typical reflux-focused treatment. This matters because the solutions are different. If reduced saliva is the primary driver, staying well hydrated throughout the day, using sugar-free lozenges to stimulate saliva flow, and reviewing any medications that commonly cause dry mouth as a side effect, particularly certain blood pressure medications, antihistamines, and antidepressants, become the more relevant practical steps. Chronic sinus inflammation. A 2024 systematic review and meta-analysis confirmed a significant association between reflux and chronic sinus inflammation, with the same pepsin enzyme responsible for throat irritation also detected directly in nasal and sinus tissue in affected patients. This explains why some people experience both throat symptoms and sinus symptoms simultaneously, and why treating only the nasal symptoms with sprays and antihistamines often provides incomplete relief when reflux is the underlying driver behind both. If you have cycled through allergy testing, multiple rounds of antihistamines, nasal sprays, and even sinus evaluations without ever achieving lasting relief, this overlapping pattern between reflux and sinus inflammation may be the missing piece that explains why none of those individual treatments fully resolved your symptoms on their own. What to expect? The timeline of improvement. Symptom relief from addressing reflux directly typically takes 4 to 6 weeks to become noticeable, and full healing of irritated throat tissue can take 3 to 6 months of consistent management. This is not a problem that resolves overnight, and it is not a problem that responds well to a single remedy tried for a few days and then abandoned. Consistency over months, not days, is what current clinical guidance emphasizes. Week 1 to 2. You may notice reduced throat clearing and less frequent coughing. The lump sensation may persist, but you may feel it less intensely. Week 3 to 4. Morning hoarseness and post-nasal drip sensation often begin to improve. You may start noticing that your voice feels less strained. Week 6 to 8. The lump sensation typically diminishes significantly. You may find yourself clearing your throat much less often. Week 12 to 16. Tissue healing continues. Symptoms should be substantially reduced if you have been consistent with lifestyle modifications. Week 20 to 24. Full tissue healing often occurs. Symptoms that have been present for years may resolve entirely or become so mild they no longer interfere with daily life. If you do not see improvement within 8 weeks of consistent lifestyle changes, it is important to return to your doctor for further evaluation. There may be another contributing factor, or you may benefit from additional interventions. When to seek urgent medical attention. While LPR itself is not an emergency, certain symptoms should prompt immediate medical attention. Difficulty swallowing that is getting worse. Painful swallowing or a sensation of food getting stuck. Unexplained weight loss. A lump in the throat that is increasing in size. Voice changes that persist for more than 3 weeks. Coughing up blood. Chest pain that is not clearly related to eating. These symptoms may indicate a more serious condition and require prompt evaluation. Bringing it all together. Chronic throat mucus that persists despite allergy treatment, particularly when accompanied by throat clearing, a lump sensation, mild hoarseness, or a cough that worsens at night, deserves consideration of laryngopharyngeal reflux, a form of silent reflux that frequently occurs without any classic heartburn at all. This happens when stomach acid and the enzyme pepsin reach the sensitive tissue of the throat and voice box, triggering ongoing irritation and a protective mucus response. The absence of heartburn does not rule out reflux. In fact, it is typical for this condition. The path forward. See your doctor and specifically mention LPR. Ask about evaluation options, including laryngoscopy. Implement evidence-supported lifestyle changes consistently. Elevate the head of your bed. Avoid meals within 3 hours of lying down. Identify and reduce personal trigger foods and manage portion sizes. Be patient with the timeline. Tissue healing takes months, not days. Consistency is the key to lasting improvement. If symptoms persist despite consistent lifestyle changes, return to your doctor for further evaluation and additional treatment options. If you have been quietly living with this for years, accepting it as simply part of getting older, know that in many cases it is not. It is a specific, identifiable pattern with a name, a mechanism, and a path toward genuine relief. Once you know which direction to look, that feeling at the back of your throat has been trying to tell you something for longer than you realized. Now you know how to listen. Disclaimer: everything shared here is general educational information based on current published research on laryngopharyngeal reflux, including clinical reviews and current clinical guidance on its diagnosis and management. It is not personal medical advice for your individual situation. Persistent throat mucus, throat clearing, or hoarseness can have multiple underlying causes, including but not limited to LPR, true GERD, allergies, chronic sinus conditions, and salivary gland dysfunction. Please consult your physician or an ear, nose, and throat specialist for a proper evaluation and diagnosis before beginning any treatment, including over-the-counter acid reducers. This information is intended as a starting point for that conversation, not a replacement for professional medical care. Subscribe for more evidence-based health information.